Welcome, everybody. Thank you for joining us for today's presentation on CMV. We're going to be talking about prevention, screening, and treatment. And just wanted to share with you that today we do have continuing education available for this. So you will be receiving an evaluation after the fact. And so if you complete that, then we will make sure to get you your continuing education. And this presentation is supported by a grant from the American Academy of Pediatrics. And it is for a SETNet and AAP chapter communication campaign. So we are in a partnership with both Iowa chapter of American Academy of Pediatrics, Iowa HHS, and the National CMV Foundation. So I'm Lori Bird. I am the program manager for AAP, the Iowa chapter, and we are fortunate to have some of our other colleagues as well. In addition, I want to make sure that you see that we have our disclosures up here. We do not have any conflict. Dr. Waddell does have, is going to be talking about some off-label use, but he will explain that later when we have him start talking. So before we get started on that, I have the privilege of actually introducing our, sorry, I'm going to stop my share. Here we go. We have our privilege to have a person that has a direct connection to CMV. She is the mother to 3 amazing children. She has achieved her master's degree in social work from the University of Northern Iowa and spent over 10 years working with and helping families. And in recent years, she made a career switch to allow for more time at home with her children, especially her youngest, who was profoundly deaf due to congenital cytomegalovirus virus. Tammy's passionate about helping families navigate the education with children with disabilities and navigating for cCMV awareness and its impact. So I just want to introduce Tammy Hoffman and turn it over to you, Tammy.
Thank you. Thank you for that sweet introduction. Again, my name is Tammy Hoffman. Thank you for the opportunity to be able to share our story with you today. I tried to condense this story down, so I'm going to just kind of hop right into it, just to save on time. But thought I'd start with sharing. There we go. Everybody see that? Okay. So my son Ryder was born in July of 2018. Can you hear me okay, Lori?
Yes, we can. It looks like your slide is just loading right at the moment.
Oh, okay. Okay. It's okay. Can I go ahead and start or? Okay. So my son Ryder was born in July of 2018. My pregnancy with him was very typical, all good prenatal visits. He was my 3rd child, so by the time that I was having contractions and got to the hospital, it was a quick delivery, and we welcomed our sweet little boy into the world. When he was born, he had kind of some freckle-like dots all over his face, and I had asked the delivery nurse what that was. She said it's likely from going through the birth canal too quickly, because he did come really fast. So I didn't think anything of it, and honestly the dots kind of lessened as our stay at the hospital was there. The next day at the hospital, the nurse came in to take him for his hearing screen, and when she came back in, she said, we'll try in a little bit. He did refer on his hearing screen, and he likely just has fluid left over from the quick delivery. So a few hours later, she came back in again, took him out, comes back and says, well, he still must have some fluid because he referred on his hearing screen again. I remember worrying about it for a little bit, but honestly, I had 2 hearing children. So, and she, with her saying that it was likely just fluid, I remember just kind of brushing it off a little bit. She comes in the next morning and takes him for his hearing screen, comes back in and says, he passed. And we kind of did a little celebration and we're like, oh, good. I don't have to worry about that anymore. And truthfully, I never gave it another thought until 9 months later. And at the pediatrician's office, I felt like something was off with Ryder's ears. He had a couple ear infections, but it wasn't, can you see the screen, Lori? You can't.
It still says loading. There you go.
Oh, because I really wanted you to see that picture. Still nothing, huh? It says it's sharing. Still not there, huh?
And you're off.
Okay. I'll try it a little bit here. Okay. So anyways, fast forward to 9 months later, I was at his pediatrician's office and was having a conversation with this pediatrician that I felt like something was wrong with his ears. He had said that he didn't feel like he had had enough ear infections to give me an ENT referral. But after kind of much conversation and a little push, I ended up getting a referral to an ENT. The first thing you do when you get to an ENT is they meet with an audiologist and do a hearing screen. And so we went through that and Ryder referred on both sides. So we meet with the ENT doctor. He says, well, Ryder had just had a respiratory virus. So it's likely more fluid in the ears. So let's check his hearing again in 6 weeks. So we wait 6 weeks, come back, meet with the audiologist. The audiologist, he says he refers on both sides. So then we are referred to Blank to get a sedated auditory brainstem response, ABR, or otherwise known as an ABR, to see what levels of hearing Ryder has. So we wait a few more weeks for that. End up learning just shy of Ryder's first birthday that he has severe to profound hearing loss. We meet back with our pediatrician. I'm kind of going through all the things that we've gone through and identify that he has hearing loss. And the pediatrician says to me, has Ryder ever been tested for CMV? And so at 12 months was the first time that I had heard the letter CMV. What CMV? Cytomegalovirus. I have no idea. So we end up taking a urine culture right there in the office that day. Ryder was positive for CMV at age 1, which we don't know if he was affected with congenital CMV at that point. But we know he was positive for CMV as a 1-year-old. So we end up getting referred to Iowa City. We meet with an otolaryngologist there who recommends to have an MRI of Ryder's ear anatomy so we can move forward with potential cochlear implants. It was during that time when they did the MRI that they noticed kind of a white lining around Ryder's brain. That is when we were referred to a neurologist and an infectious disease specialist. After meeting with the infectious disease specialist, they were able to pull Ryder's newborn blood spot screening and send it to a lab to be able to test it for CMV at birth. After several weeks of that, we received confirmation that Ryder was in fact born with congenital CMV. So our family has since then put kind of all the pieces together that Ryder was born symptomatic to congenital CMV, and we had no idea. Obviously we don't screen every baby, but because our family, at that point went through kind of this diagnostic odyssey, which was extremely stressful. And that leads us to today, where we are passionate about advocating for congenital CMV, and testing babies so that they don't miss out on those early intervention services. Ryder's late identification to CMV led us to miss out on 13 months of early intervention services. It made us miss out on any potential antiviral treatments, and just kind of an overall delay in helping Ryder kind of navigate through the future of his life. I'm going to try one more time to share the pictures. Oh, can you see it now?
Yes.
Yeah, okay. So this is the picture that I really wanted to show. I didn't I had to go back through this once we figured out that he was born with CMV, but it was just a real light little dots on his face that he was born with, that I do think was probably related to the virus. Here's his first day of having a hearing aid. This was right before he was sedated for his MRI. Here's his wild child side. I always think it's just kind of important to get a picture with the story. And yeah, I'd be open to any questions that anybody might have, but thank you for listening to our story. I hope we can all learn from it and have a positive impact on families in the future.
Thank you so much, Tammy, for sharing your story and sharing the impact that CMV has on a family and kind of your experience. I appreciate your time. And now we're going to turn it over to Kimberly Noble Piper, and she is going to give us some more information on kind of the state of screening for CMV.
Okay, I'm trying to do my sharing mode or my screen presentation mode. Are you guys able to see it in presentation mode or in
presentation?
How about, did that help?
Yep.
Okay, yay. Gotta love technology. So I am Kimberly Noble Piper, and I'm the director of the Center for Congenital and Inherited Disorders at the Iowa Department of Health and Human Services. And the Center for Congenital Inherited Disorders also encompasses all things newborn screening for the state of Iowa. I've been in this role for about 20 years. So we were just talking earlier how we don't feel as old as we are. This is an example of this, but I'm very happy to be able to present about the laws and regulations surrounding congenital cytomegalovirus screening in Iowa. And I have no financial relationships or conflicts of interest to disclose for this presentation. In 2017, Governor Reynolds signed into law Senate File 51, which was an act relating to a cytomegalovirus public health initiative, and then the testing of newborns for congenital cytomegalovirus. And there are two sections to the law. The first section regards development and publishing of educational materials. And this section amends Iowa Code Chapter 136A.5B. Don't expect anybody to care about that, except for me, maybe. That chapter is the main congenital and inherited disorders chapter for the state of Iowa. And then the section regarding testing of newborns diagnosed with hearing loss is what the law says, which means they did not pass their newborn hearing screening. That section amends Iowa Code Chapter 135.131, which was our main chapter regarding hearing screening. One thing to note is that no funding or authority for oversight of congenital CMV screening in Iowa was provided to the Iowa HHS through this legislation. So we had to work with the resources that we already have.
Sounds about right.
Is there a question out there? No? Okay. The first section of the new law requires the Iowa HHS Center for Congenital and Inherited Disorders to develop and publish informational materials to educate and raise awareness to various audiences about CMV and congenital CMV. And as you'll hear how important it is to raise awareness. And like Tammy just described, she'd never heard the letter CMV until he was a year old. So we aim to prevent that through this work, through this legislation here. The target audiences for these informational awareness materials are to include women who may become pregnant, expectant parents, parents of infants, attending healthcare providers, and others as appropriate, such as daycare providers. And the one thing to note here for prenatal care providers, they're required to provide these materials to pregnant women during their first trimester of pregnancy with this law. And I don't think that's something that many providers are aware of, is that they're required to present this information to their pregnant clients.
This weekend, I do have a night.
To comply with the law, Iowa Health and Human Services has worked with various partners to develop awareness and educational materials. We've recently worked with the AAP to develop materials for providers and consumers, which has been great. And then Iowa Health and Human Services Center for Congenital and Inherited Disorders also has materials available on our CMV web pages. And I've included the link here for that. And then another wonderful resource is a National CMV Foundation. They have a wealth of information for providers, consumers, parents of affected children, and for policymakers. And I've linked their website here as well. This is an example of the congenital CMV flyers for providers that was developed in partnership with the American Academy of Pediatrics, with the Iowa chapter here. And this is just more pages of the provider flyer. And this is an example of the flyer developed for consumers and pregnant women that speaks to prevention efforts for people who are pregnant. And these will be available with the slides that Lori sends out later. The next section of the law speaks to the actual screening requirements for congenital CMV, and this includes two main requirements for providers. The first requires testing of the newborn within 21 days of a failed hearing screen. And by failed hearing screen, we mean the newborn did not pass their initial screening and rescreening for hearing loss, or that they referred for hearing screening. And we do the testing within 21 days to allow determination that the CMV was acquired congenitally and not through the external environment after the baby was born. And the second requirement is that providers are to provide information to the parents of a child diagnosed with CMV that includes information regarding the birth defects caused by congenital CMV and early intervention and treatment resources for services available for children diagnosed with CMVs. And this is an example of a recommended algorithm that you can use to screen newborns for congenital CMV. So basically, if the newborn does not pass their initial hearing screening, in addition to referring the newborn to a diagnostic testing center after a failed hearing screen, of course, you should proceed to collection of a saliva specimen from the newborn. And ideally, this should happen at least an hour after breastfeeding. And this is required to be done before the newborn is 21 days of age, like we had mentioned before. And then usually confirmation of a presumptive positive CMV test on saliva is to follow up with urine and saliva testing, which should also be completed by 21 days of age, again, to help distinguish congenital infection from an infection acquired through the environmental exposure. The standard laboratory test for diagnosing congenital CMV infection is polymerase chain reaction, or PCR, and that's done on saliva with urine usually collected and tested for confirmation, like I said before. The reason for the confirmatory testing being done on urine is that most CMV seropositive mothers shed CMV in their breast milk. So that can cause a false positive CMV result on saliva collected shortly after the baby's been breastfed. You cannot detect a newborn infection using tests that detect antibodies to CMV, because again, that all depends on the viral load. And speaking to that, I need to say a note about using dried blood spots for congenital cytomegalovirus testing. And while dried blood spots are already collected on virtually all newborns in the United States and of course in Iowa, and there are 2 states currently screening blood spots for congenital cytomegalovirus, Minnesota and New York. And I believe Connecticut is coming on board with that pretty soon. There's still, that's not the source of choice for congenital CMV testing. The CMV viral loads in blood are approximately 2 logs lower than viral loads in urine or saliva. So that's why we start with those. But there have been a lot of improvements in the testing and validity that can be obtained through using dried blood spots specimens for CMV testing, and the methods for DNA extraction and PCR should allow for better sensitivity in the future. So stay tuned. We'll see what happens through the course of Minnesota, New York, and Connecticut's testing for this. Another regulation that we have in place is a reporting order. And the director of Iowa Health and Human Services, Director Garcia, signed a reporting order that temporarily designates laboratory results from CMV testing as reportable in Iowa. So this means that any lab who does testing on an Iowan for CMV is required to report those results to the Iowa Department of Health and Human Services within 3 days of that result being made. And we send that information to the Iowa Registry for Congenital and Inherited Disorders, which is our birth defects registry. And then the registry will parse out cases of infants that are less than or equal to 42 days of age, and then women of reproductive years, which we're calling 15 to 49 years old. That is our targeted audience. And we do this in order to see what the idea of to kind of get an idea of the CMV rates and targeted populations. And then we're able to match this with other data sets, like our hearing screening data, to determine if testing is being conducted and what those testing patterns are. And so far as of yesterday, we've tested, there have been 920 newborns tested, with 9 of those infants having CMV detected. And then for the women of reproductive age, 466 have been tested, with 113 detected as having CMV. And that's all I have for my section. I do want to say thank you to the CDC Surveillance for Emerging Threats to Mothers and Babies Network, or SETNet, and the American Academy of Pediatrics Communications Campaign to address emerging threats to mothers and babies for funding to develop
If you have
CMV.
any,
And then thanks to the Registry for Congenital and Inherited Disorders for the CMV testing data. And I do want to make a note to have providers please look for a survey coming out in the next couple of months from us here at the Iowa Department of Health and Human Services. Dr. Linda True will be sending that out to providers, and we're trying to get an idea regarding their awareness of congenital CME and their practice patterns. Thank you.
Thank you, Kim. Now I'm going to turn it over to Dr. Joel Waddell. You ready to go?
Yeah, here we go. Let me see. I'm going to share my slides. Most likely, I'm going to share my slides. Let's see. Okay. Okay.
I could pull them up if need be.
Can you see that okay? What's that?
Yes.
I'm sorry.
Yes, no, we could see that.
You can see that. Okay, awesome. And it's in the presenter mode. It's you can see that. Perfect.
Oh, no, now we just see the screen. We don't see your,
Gotcha. Okay, let me
try stopping share.
think what happened. Quick. Okay. I think this will do it.
We see the daily point.
So here we go. My computer decided to be slow all of a sudden. I think it should be loading up. But yeah, as this is going, so yeah, I am Joel Adell. I'm one of the pediatric infectious disease doctors here in Des Moines at Blaine Children's Hospital. Very happy to be part of this group.
If you want to stop your share, I'll share my screen.
Perfect, yeah.
Can you see the presentation now?
Yes, and well, actually mine just popped up, so I think,
Okay, I'll stop my
sorry,
share then.
making me difference. Okay. There you go. So, can you see the disclosure slide now? Perfect, up and running. Yeah, I have no financial disclosures. As a caveat, more of a caveat than a disclosure, this is not an all-inclusive discussion about congenital CMV. Some topics, a couple specifically, are, I guess, controversial is the right word. I would just, maybe it's a better way of saying there's just differences of opinions. And I will point these out when I come to them. So congenital CMV has many different clinical manifestations. And so there's just a very, very wide array. I think, for those of us providers, most of us were taught a very specific triad of congenital CMV, chorioretinitis, calcifications, microcephaly. But that triad is actually not terribly commonly seen. And in fact, the most common clinical presentation is no symptoms at all at birth. So completely asymptomatic in 9 out of 10 babies. And then symptomatic disease can be mild or even moderate to severe. And then a little bit of debate about how you classify a child with isolated hearing loss. But for this purposes of this talk, I'll kind of put that as a different disease presentation. There are European guidelines on congenital CMV, and then there is an international group that's different than the European guidelines that have their own thoughts and some differences on congenital CMV. But I think it's easiest to kind of call mild disease as maximum of 2 clinically insignificant or very transient findings. And so that would mean maybe at birth there's very mild hepatomegaly, only a slightly enlarged liver, not very enlarged and not including large splenomegaly. Or maybe you have a 1 count of a low platelet or a 1 elevated ALT, a liver enzyme. But more significant disease, so of course, any life-threatening congenital CMV disease is automatically considered severe. or if you have multiple manifestations of the virus. So this would be thrombocytopenia, petechiae on examination, hepatosplenomegaly, IUGR. A lot of babies can be born with active hepatitis from the virus, meaning the liver can be quite inflamed. A lot of us in training have kind of learned the term blueberry muffin rash, and that's when you get hematopoiesis in the skin itself, or any CNS involvement. And so CNS involvement, we are taught that's calcifications, but that's one possible manifestation of central nervous system involvement from CMV. Certainly microcephaly is a known cause, so significantly smaller than average head circumference. If you are able to detect CMV virus in the CSF, that alone says you have central nervous system involvement. Not saying that every baby who has CMV gets a spinal tap or a lumbar puncture. And then, of course, any abnormal neuro exam or any presence of seizures, that's gonna be fairly significant. And then any eye findings such as chorioretinitis. And then, like I was kind of saying, we all kind of learn, calcifications when it comes to CMV, but there's just a large array of what we can actually attribute CMV to causing CNS disease. And one of the things that can happen is it can cause neuronal migration abnormalities. So as the brain's developing in the womb, you get neuronal migration and the development of fetal brain cells, and that can be disrupted. And as you would imagine, that can have enormous consequences. And so on this picture on the left, you can see the little white spots popping out. Those are the calcifications. And what has happened, though, is it's not just calcifications. So we have very simplistic gyral pattern of the brain here. And so it's actually easier to see that on the right side. So there's not, it's supposed to be much more bumpy, for lack of a better word. And so if it's smooth, that's indicative of a pretty significant CNS disease. And then we have these prominent ventricles. So on the bottom, you see these very large black areas. They're not supposed to be that big, and they are that big because the brain has not developed enough. And on the right, this picture on the far right, what you see is that there's a discordance between the right and left brain development. And so on the right side, which is on the left side of your screen there, you have the cerebral hemisphere is much smaller, and it's also much smoother. So if you compare if you can see my arrow, the smoothness on the left side of the picture, right side of the brain, compared to the other side. And what that has done is resulted in significant volume loss of the white matter of this side of the brain. And so the classic petechial rash with jaundice present, the jaundice is there because you get hyperbilirubinemia present, and then microcephaly, as you can see. So I think it was 2014 or 15 when everybody started hearing about Zika, which I think to every ID doc out there, like, this is important to talk about, but if we're trying to raise awareness about congenital infections that can cause microcephaly, why not talk about CMV, which is outrageously more common than Zika, but still to this day, as Tammy pointed out, a lot of people still haven't even heard the word CMV, even though they've had 2 or 3 kids, which, I think we can improve upon. You can get more severe disease where you have frank liver failure, which is pretty bad, or you can have moderate disease where nothing's life-threatening, but you have a lot of manifestations. Now, this is a really important slide. So what do we mean by isolated sensory neural hearing loss? So that's kind of what it sounds like. Child is born, they only have hearing loss. They don't have any other findings. This is the leading non-genetic cause of hearing loss in the United States. And it happens up into half of babies who have symptomatic CMV at birth. But importantly, it also happens to around 15% of babies who are asymptomatic at birth. That means you're going to miss every single one of those at birth. And then about 40% of babies who develop hearing loss have no hearing loss at birth or even in the first month of life. And so that late onset aspect is really, really important. And this isn't in black and white. So the hearing loss can be quite variable. So you can have mild hearing loss that's unilateral, or you can have, to the other extreme, profound bilateral loss, where things like cochlear implants need to be considered. The majority of babies, fortunately, do survive congenital CMV, but the mortality is not insignificant. But then of those who do survive, developmental delays and even cerebral palsy can happen later in infancy or even early childhood. Developing cerebral palsy or significant delays is not terribly common in babies who are born asymptomatic. And so it's important that we understand transmission because that can help us with prevention. And so the biggest transmission exposure is through urine or saliva. Kind of like Kim was talking about earlier, there's a much higher viral load in saliva and urine compared to other, even blood products. But it technically is sexually transmitted infection as well, and it can be expressed in breast milk and even tears. So this second point down here is really important. So young kids are a very important source of CMV infection, and the reason is they have very high levels of viral shedding in their saliva and urine. And we see higher rates of infection in kids going to daycare. And so if you think about this, you have little kids who have large amounts of CMV in their saliva and urine who are kissing you all the time, and you're having to change their diapers or helping them wipe all the time. So that's a really big risk. Of course, there can be vertical transmission that occurs transplacenally. And about a third risk of transmission if a mom gets their primary infection during pregnancy. But it is quite possible for a mom who has been infected with CMV in the past. So when the mom was in daycare, she got CMV. When she was 2 years old, maybe, it's very possible that this virus can reactivate, not harm her, but harm her baby. And actually, about 3/4 of CMV infections in babies comes from women who are not with a non-primary infection. So there's no CMV season, but it is outrageously common. So about 1 in 200 kids in the U.S. Are born with congenital CMV infection. It's higher and lower in certain populations. So about 1 in 100 babies born to Black women have congenital CMV. These are pretty darn high numbers. There are some risk factors. So young maternal age, direct care of young children. So if it's a second or third or fourth child in the family, or recent onset of sexual activity, or maternal HIV. So kind of like Kim was talking about, antibodies are not very helpful in diagnosis. For one, IgG is definitely not going to be helpful for testing the baby, because that's going to be maternal IgG, and IgMs have a very high false positive rate, and for newborns, the false negative rate would be fairly significant as well. And so if we do test, we're going to use the PCR. We do usually start with the saliva because it is quite sensitive. You just have to make sure you're doing the timing correctly after receiving breast milk. You can, if it's in the blood or in the CSF, that is certainly a positive test and confirms a diagnosis, but the sensitivity of either of those is not as good. And Kim already kind of touched on the dried blood spot and questions of sensitivity, but maybe they'll improve in the future. So over a decade ago, probably the standard of care if treatment was initiated was 6 weeks of IV ganciclovir. But then David Kimberlin out of Alabama, who he's the main editor of the Red Book for the AAP. He did a New England Journal of Medicine study where he compared that standard of care, 6 weeks of IV GAN, to 6 months of oral valganciclovir. And what he and his team discovered was that the babies who got the 6 months of treatment actually had better audiologic outcomes and better developmental outcomes at 2 years of age. And kind of the idea there, and the way I kind of explain it to parents is CMV is just like HSV, it's just like chickenpox. It lives in your body forever. And if the virus wakes up when the baby's 2 months old, it has the potential to harm their brain and harm their hearing even further. And so we give the baby a little bit of a break for 6 months, and we help keep the virus asleep with valganciclovir. And then after that, their immune system can take over. And we do usually treat for moderate or severe disease. For mild or asymptomatic disease, we don't usually treat. But what about those kids who just have hearing loss? I don't say just to minimize the impact of hearing loss. I say that as there's no other findings, what do we do with those children? This is one of those controversial areas I mentioned as the caveat. So the current published American Academy of Pediatrics Red Book says treatment not routinely recommended. The International Consensus Guidelines says the same thing, so it seems pretty consistent. But the European guidelines, the majority of the individuals on that panel agreed that treatment for isolated hearing loss was indicated. And then a year later, a study out of Israel at 59 children and gave them Valgan for 6 months, and most had improvement of their hearing, with the vast majority returning to normal hearing, which that by itself is pretty remarkable, because I think before this study, no one ever really anticipated that hearing could improve. And in this study, only 2% of kids' hearing deteriorated. So that was a small study. It was retrospective. And so a group out of the Netherlands published a study. It's e-published. It'll be physically published in May. It was a prospective study where they did 6 weeks of oral Valgan, and they had less hearing deterioration. So the rumor mill has it that the new Red Book that will come out this year will likely recommend, if at least allow for treatment. Be interesting if they say 6 weeks versus 6 months. I will tell you, as a full disclosure, I am probably in the minority of ID docs currently in the United States, in that I do usually recommend treatment for isolated hearing loss. And I will tell you anecdotally here at Blank, we have seen pretty impressive results of children's hearing improving. That is certainly not 100% of cases, but a large amount. So Valgan does have side effects. Neutropenia is the most common, and if your ANC drops below 500, you just pause it for a week. So it's not insignificant. We have to check labs once a week for a month and a half, and then space it out to every month after that. So now moving on to prevention. It'd be great if there's a way to prevent congenital CMV and not even have to worry about antivirals. And so Kim outlined some really wonderful educational materials on how to prevent. But basically, the short version of this, try not to come in direct contact with a young child's saliva, that it doesn't touch your mucous membranes, and the same thing with the urine. So don't share food, drinks, utensils with your young kids, and then don't put child's pacifier in your mouth. So as an ID doc, when I see my friends do that with their children's pacifiers, my whole body cringes a little bit, but it's especially important when thinking of preventing congenital CMV. And then anytime you change a diaper, make sure you're thoroughly cleaning your hands if you touch their diapers or wipe their nose, which happens every day for every kid in daycare. These preventive measures have been shown to statistically decrease the occurrence of congenital CMV infection in pregnant women. So there's something called CMV hyperimmunoglobulin. This has not been helpful. This is when you give a lot of IgG, and it makes sense because moms are probably making IgG anyways, and so that's not terribly helpful. Why don't we just give Valga and cyclovir to moms? So a few years ago, a prospective study was done with 100 women, and it did reduce the rate of congenital CMV infection fairly significantly. No adverse events were encountered, but this was only looking at women to prevent primary CMV. So as you remember, most babies who are born with congenital CMV have a mom who's had CMV in the past. It's a reactivation. It's not a primary infection. And there's a theoretical risk of ganciclovir, and therefore Valgan can cause gonadodysgenesis in animals. So let's vaccinate. So 2 vaccines have demonstrated 50% efficacy, but licensure is years and years away. So the conclusion is, how do we prevent? The best method is prevention with education. So for follow-up, audiology follow-up is outrageously important. And so it's usually even every 3 months or so in that first year of life. You want the child to see a pediatric ophthalmologist. And then here's how I handle the developmental screens. If the child has asymptomatic disease, asymptomatic or isolated hearing loss, then I will just recommend well-child checks. But if there's severe disease, then I'll refer those children to a developmental pediatrician. I'll bring up the last point about dental checks, not because it's terribly common, but because if you don't bring it up, parents will read about it. But rarely, congenital CMV infection can be associated with abnormalities of the primary teeth, of the baby teeth, and so you want to make sure they're getting their regular dental checks. Here is the second controversial area I wanted to bring about. So what about universal screening? Why don't we just test everybody and then see what happens? So there's a few options. You could test every mom for CMV during pregnancy. Not completely unprecedented. We do that with syphilis and some other things. Or we test every baby who's born. Or we do what we're currently doing and only test babies who fail a hearing test. Or we don't do any asymptomatic kids. So a lot of important considerations over our last couple of slides here. So one is cost. What are the benefits of screening? What are the risks? So maternal screening. Benefits, I mean, you could potentially detect women at risk for having a child with CMV. But the prevalence in some communities can be over 50%. I was just doing some math as Kim was bringing up that slide. It sounds like around 25% in your early data so far in Iowa. But most moms who are IgG positive with CMV will not have a child with congenital CMV. And so you potentially induce some anxiety there unnecessarily, and then we're not going to give antivirals to moms at this point in time. So there's really no actions that you can do. No country recommends this. So universal neonatal screening is recommended by many developed countries. The international consensus guidelines say that they recommend consideration should be given to universal screening. It's not currently done in the United States, with the exception of Minnesota and New York. And Connecticut will be again next year. So what are the risks? So the argument would be, well, if we screen and the baby's positive, there's nothing we can do. There's no antivirals that can be given. So why screen if there's no actions to be taken? Cost. Won't this be horribly adding cost to an already overburdened healthcare system? But the opposite is actually true. It actually results in cost effectiveness for on a population level. Do we have enough resources? Very good question, especially with our audiologists. Or are we just going to flood them with lots and lots of babies and not have the opportunity to do it? And then the last one is, if you test every baby, 1 in 200 are going to be positive, and you're going to cause all those parents anxiety. So we're going to come back to this. So what are the benefits? So you have significant amounts of non-pharmacological interventions that can be done. You're going to have improvement in receptive and expressive language. And we know that because a stat I'll show in a second, but babies who get interventions before 2 years of age have much better development. You can get children into speech therapy, occupational therapy. You can get hearing aids. So hearing aids can be done in very young infants. And even if they wear it for an hour a day, I'll tell the families, hey, talk their ear off while their hearing aid is in to help their development. And then vision impairment is an important one that we would screen for as well. And so here's what I was talking about. So in a child who has asymptomatic congenital CMV disease with normal hearing before 2 years of age, no difference in IQ, vocabulary, etc., compared to controls. But in a children who are asymptomatic at birth, who develop hearing loss by 2 years of age, intelligence and receptive vocabulary scores are much lower compared to their controls. So you can see that doing interventions early has significant potential for benefit. What about that big risk, though, parental anxiety? So this has been addressed already. So the study from the UK looked at maternal anxiety at birth and 3 months, and when tested for congenital CMV versus controls who didn't have CMV. And there's actually no difference in anxiety. And the vast majority, 97% of moms said this was a good idea. I'll tell you anecdotally, I've seen a lot of moms and dads who are very frustrated with their lack of knowledge about CMV. And again, this is anecdotally, but I will tell you, I have overwhelmingly seen parents who prefer to know about this diagnosis. So summary, it's very, very common, wide array of presentations. We do need to improve our education. A couple of controversial or debatable topics about treating hearing loss alone and universal screening. I respect people who disagree with me on this. A lot of good docs do, but I've kind of outlined my personal opinion. Here's my references, and thanks for letting me present. Sorry I went a little over.
No problem. Thank you, Dr. Waldell. That was really interesting. We've had a couple questions in the chat. One being, let me pull it up here. Dr. Secker said many newborns will have epithelium mostly on their face due to birth trauma and nuchal cords. Do they need testing for CMV? You are muted, Dr. Waddell.
I mean, that's a very good question, a fair question, because a lot of babies do have those changes. I would say if there's any slight hint of significant jaundice associated with this petechiae, I would have a very low threshold personally of screening. If there's a few petechiae alone, I don't know that I would necessarily. I don't think you're obligated to test. Of course, this issue would become moot if we did universal screening. But if you're ever on the fence and you're not sure if this is normal or not, it's a simple saliva test. I would have a low threshold to do it.
Great, thank you. I know we're right at 1, but if there's anybody that has another question, we'd be happy to answer at least one more. Okay. Well, I just want to thank all of you for joining us. Thank you to Tammy and Kim and Dr. Waddell for their information and their presentations. And we just thank you to all of you for joining us today. I will be sending out emails to all those that registered with the PowerPoints, with the link to the recording, and also the link to the materials that were mentioned and the evaluation. So you'll be seeing that from me. So thank you again very much.
Thank you.
Thank you.